Hello, Bruce.
How are you, Innocent?
Fine, how are you? I am actually supposed to make another presentation. I'm in the Prima Farmedi conference, but Jane should be coming on. Just wondering how many people had registered for this webinar?
To be honest, I haven't had a look. It was just it was such a bit of a rush near the end. I just got it out, and I haven't got back to having a look and see how many people have registered. But there's quite a few people got back to us saying that they were interested. So hopefully they'll be here.
Okay. So I will just join in a bit late, but I have discussed with Jane. She will be coming on, then I will join you along.
So are you, you're not going to be at the start?
But I thought people had come so that we could see whether we start, because I'm also starting here shortly. But Jenny will do everything, then I will join the discussion.
Right. So will you be introducing Jane, or will you want me to?
You will introduce Jane.
Okay, and you'll join the discussion.
Yes. Yes, later. Yeah. So I think that the best way to do it is that you kickstart everything, introduce Jane, and then Jane will manage the rest of the process.
Okay, that sounds fine. I'll sort that out with Jane when she comes on.
Okay. Okay. See you later.
Yeah, see you soon. Good evening, Jane. We'll just wait a moment just to see if we can, if a few more people come online. How are you?
Fine, how are you?
Good, good. I understand that Innocent's got a clash with something else, so I'll just do some introductions in a moment, and then I'll hand over to you.
Yes, I see Dr. Betty is already with us. She will make a brief presentation so that she can trigger a discussion from members.
Very good. So we'll just wait a couple of minutes, see if a few more people. I know a few people joined earlier and then left. They must have had the wrong time zone, but I think we're hopefully going to have them soon.
True.
I'm just trying to see if I can live stream to YouTube. For some reason, it must be a bit congested, but so we're not appearing to be able to live stream to YouTube, but we can certainly download it afterwards so that people can see it.
That would be good.
We'll just wait a few more minutes and see.
Hi, Jane. Hi, Dr.
Hi,
Jane.
Betty. How are you?
Good. I'm fine. Good afternoon.
Good afternoon to you. We are waiting a few minutes.
Okay. To have more people join?
Yes.
Okay. That's fine. Hi, Dr. Bruce.
Hello, it's Betty, is it?
Yes. Good evening. It's evening, your time.
Yes, it's 9 o'clock with us. So yeah.
Oh. Nice meeting you online.
Yes, just beautiful. Thank you.
Well done,
Where
sir.
are you, Betty? You're in Nigeria.
I'm in the north. Yes, I'm in the northwestern part of Nigeria.
Right.
Yeah. I practice in one of the states in the northwestern zone, Zamfara State.
Is that one of the more dangerous places, or?
But I didn't get that, please.
Is it one of the more dangerous areas there? I know you've had some problems.
Oh, you are right. Yes, it's one of the most most dangerous areas as at present. A lot of security challenges are ongoing. The military personnel are working hard to ensure everything is controlled.
Yeah.
So yes, it is a dangerous zone for now.
Yeah. I'm conscious of everyone's time, and I don't want to hold everyone up, in particular those who've been gracious enough to come and join us tonight. It looks a bit disappointing. We've only got a small number, but I'll be the token man, and we can have a good discussion with the women of the group. And thank you very much for joining us. I can see we've got Betty, we've got Barish, we've got Janine, and Jane. So we might as well, if you like, we can turn our cameras on and make it a bit more personal for us all. Betty, we could just see the bit of the top of your head more than anything. You might just I don't know if you can bring your camera down just a bit. We'll get a better shot of your face just to say hello. That's good. And I don't know if Janine or Barish would like to. Barish, welcome. You could join me.
Hi there. Hi, Bruce. This is Barish.
You could balance up the gender numbers.
Hello.
So, and Janine, would you like to show us your camera? Is that something you'd like to do?
Sorry, I'm struggling a bit with my internet connection.
All right, that's fine. That's fine. Look, it is a bit disappointing. We've only got a small number of us, but I think we'll crack on with things, and hopefully others can either join us or have a look at the recording later. Everything is a bit unstable on the internet tonight. I've just tried to screen this to YouTube, but it's just not going through at the moment. But we'll crack on, and we'll certainly have a recording of this on our Rural Wonca website. So I'm Bruce Chater. I'm the chair of Rural Wonca, and it's great to have you join us tonight. I think women are the very fabric of rural communities, and they're often the carers and the health providers in rural communities. So tonight's a good chance to have a look at the role of women in rural health. We've got a Rural Women's Health Month, actually, and I'll talk a bit about that at the end. But we have a WHO webinar next week about workforce and rural women, and then there's a PHC Afro PHC webinar the week afterwards with respect to rural health and women in health. So the 15th of October is actually the International Day of Rural Women, and so it's a chance tonight to have a look at some of the promise that there is for rural women in being able to contribute to their communities and our professions as well. There's the challenges that those women face, their hopes and their futures, and certainly we want to try as much as we can to support and encourage women to be active participants and in fact leaders in rural communities. So I'm going to hand over now to Jane. Jane Namatovo is the president of the Association of the Family Practitioners of Uganda. And Jane, I'll get you to give an introduction on behalf of rural women and rural female practitioners, and to introduce our speaker and allow us to have some discussion then. So welcome, Jane.
Thank you, Bruce. I would like to welcome the members present for this meeting. we are running these serial webinars on behalf of Wonca Rural, the conference that we were supposed to have in Uganda. But because of COVID, we are unable to, but we thought we still won't miss out. We work hand in hand with the WHO webinars. Just before their webinars, we have the introductory weeks and then crown it with the WHO webinars. So this time round, before the 15th of October, we are having the rural, African rural women to look at the experiences they go through, but also the patients that they care for. And this time round, we are happy to have one of our colleagues from Nigeria, Dr. Fatusin Balatito Betty. She's a consultant family physician who is currently working with the Federal Medical Center in Northwest Nigeria. She's a strong advocate for family medicine education and lifestyle medicine. This reflects in her role as the leader in the education and training group in AfriOne, which is one of our Wonca Africa League for the youth doctors movement. And she's also part of the research collaboration AfriOne working group. And we are very pleased that we are going to share her experience in her context, which I'm sure will relate a lot with many of us in the places where we work with rural women. She's passionate about lifestyle medicine, and she's also a member of the lifestyle medicine in Nigeria. Dr. Betty, you're welcome.
Thank you, Dr. Jane, for that introduction. It is well appreciated. And I don't know, can we go ahead now? I would need
yes,
maybe you to enable me to share my screen, or you can project my slides from your end, whichever works for you.
Dr. Bruce, can you make her a host so that she can share her slides?
Any participant can share, so you're able to share. So if you just go to the bottom of the screen, you'll see the share button and you can share. Excellent, thank you.
Okay, can you see my screens?
Perfectly,
okay.
Thank you.
Right. So hi, everyone. I bring you all greetings from Nigeria. Professor Bruce and all other senior colleagues here present. And all colleagues here present. I am glad to be a part of this presentation today. And I must appreciate Dr. Jane for giving me an hint on what it entails, what is expected of me for this presentation. Thank you, Dr. Jane, once again. So I will be sharing with us briefly about my experience as a woman doctor working in a rural area. And I will follow this brief outline, share a little about my world as a woman, family physician, a little about my career development, what I do to ensure that I'm still relevant career-wise, and a little about the women patients I see daily in the clinics. Also talk briefly about the advantages of practicing in a rural area. And of course, there are challenges. So I will share also how I'm navigating through the few challenges here. So this picture is the entrance to the hospital where I practice. This is Federal Medical Center, Gusau, in Zamfara State. The hospital is located in the state capital, in the heart of the town. However, the family medicine department of this institution cater for patients from rural environment. So basically, family medicine offer primary care. So we see patients from villages and surrounding towns in about 80% of cases. So this is where I practice. And it is the only tertiary hospital in the entire state as of now. And as of today, we are only 3 family physicians in the entire state, and I am the only female family physician in the state for now. However, we have younger colleagues who are interested in family medicine now, who are in training. So in few years, I'll be proud to have like 3 of them join me as family physicians. So a little about the community where I work. This picture shows parts of the community. This is their central markets. You can see these are the typical people that I attend to daily. You can see women in veil because Islam is the predominant religion in this environment. A study done in South Africa by, I think, the study reported that the number of female doctors in Africa is actually growing, but it still remains lower than their male counterparts. And I can attest to that because the inequality is more obvious in the rural setting. Like I said, where I work, we are just 2 female consultants. My other colleague is a pathologist. And in the entire states, I am the only female family physician. So it is, and the reason for these inequalities can be explained by the fact that working in a rural environment makes it difficult for a woman to attain work-life balance because you have to think about your family, your children, especially if you have children, good schools, social amenities, and other things that may not necessarily be your needs, but will be essential part of your family needs. So those could be one of the main reasons why women would rather prefer to work in an urban area where all facilities are available. So the woman doctor must be able to juggle different issues to maintain work-life balance. This is a glimpse into my world. So I've told us that I'm the only female physician. So the average number of patients I see daily is between 20 to 30 patients. I run clinics every day. In between, I have to do ward rounds and attend to emergencies. That's maybe someone with an acute infection, acute abdomen, that I quickly need to refer because the family medicine department here is only able to admit for like 24 hours. So any patients that we require medical care beyond that will be adequately referred to our emergency department, though still under the supervision of the consultants who admit the patient. So that is what I do daily for patient care. So I also double as the training coordinator of our resident doctors, about 10 of them now. And they are in like the second year of their training. However, we have one senior resident doctor who is already through with the first phase of the training, and in about 2 years will become a consultant family physician. Sometimes I equally do administrative work. I'm a mother of 2 children, ages 10 and 6 years. I live here together with my husband. Unfortunately for me, he's also a family physician. So it's, so it's like a family thing, family medicine. We're both family physicians working in the same department. So that makes it a little flexible for me to share responsibility at work. And we are able to juggle things. Maybe when I'm on leave, he has to be at work. When he's on leave, I have to be at work. And that has not really made it easy for us as a family to have a vacation and all that. So until we have more hands, maybe when our resident doctors become consultants and we're able to leave the department for them. So regarding my relationship with colleagues and other health workers, we have no challenge of gender discrimination. Every doctor is respected, and they don't discriminate between the gender. I'm entitled to what a male colleague is also entitled to. I can share my opinion freely. I can make contributions. I can be part of the Doctors Association here. In fact, I recently dropped the post of the secretary for the medical consultants here, which I did for 2 years. So females are well accepted as doctors in my environment. What I do to ensure that I stay relevant in the profession, I will say access to the internet really gives me a great opportunity to connect with the outside world, to do courses to develop myself, and equally give me opportunity to meet with my colleagues to do research. And like it has been mentioned in my introduction, I am able to connect with everyone also because there is internet availability. So it's been, I would say it's been easy for me to grow career-wise because I have access to the internet in this environment. Now, briefly about the patients, my women patients, yeah, they feel more comfortable seeing a female doctor. And that is usually because of their culture here. A female is not expected to speak with a male who is not a husband or a family member. So they usually come to the clinic shy, looking down, but once they see me, oh, they are free, they are able to talk and onboarding their mind. So they feel a lot comfortable seeing a female doctor. Their health views and beliefs are influenced by their culture and family. An example that readily comes to mind now is about a condition they refer to as ISCA. They believe that is a condition when a woman is manifesting some psychological issues, maybe like depression. They feel like the person is under a demonic possession, that it is not a medical condition and all that. So we really have to talk to them, to speak to them, that actually if they see someone with ISCA, they should bring such a person to the hospital and allow the doctor to attend to the person. They are mostly uneducated and at times depend on their husbands to communicate their health needs. That's communication gap, experience that at times. So I sometimes have to include my nurses to act as my interpreter. And some of them are victims of kidnapping and rape due to the ongoing insecurity challenges. We see some of them come after they have been released or after spending days in kidnappers' den, coming to the clinic with unwanted pregnancy and things like that, traumatized, having PTSD. You know, those are some of the challenges that my patients go through here. And equally, some of them, because the divorce rate is very high here, divorce is very common, and a marriage can break up after a month or 2-3 months. So the women are usually at the receiving end. So depression is something I see a lot of time, mostly because of that. And at times I just have to act not only as a family physician now, but as their friend, so to say, come down to their level, make them feel happy, so that
Looks like we might be having a bit of trouble with
from
Betty's connection
studies,
for just a
still
moment.
record maternal mortality rate.
Yeah. So we lost a little bit of what you said there, Betty. It just went frozen for a moment. Ah, we've lost it completely. She should be able to come back hopefully in a moment.
I hope so.
Jane, just while we're waiting, oh, here she comes.
Yeah.
You're back, Betty.
Sorry,
That's great.
You lost me briefly.
Yeah, we lost you for
I'm
a
sorry
moment.
for that. I'm hoping to have a very stable network all through. Sometimes we have fluctuation in the network. So I stopped. Let me continue to share my screen.
Okay.
Okay.
Yep.
All right. Okay, so I was talking about the health issues that are common here. So maternal mortality ratio is still very high. And the reason, one of the common explanation to that is because there is this belief that a woman who delivers at home is courageous. And men usually wants to marry from such families that, oh, this is a family of courageous women that don't have to go to hospital to deliver their babies. So that happens a lot of time. Another factor is grand mortality. A woman can have up to 10 deliveries, even much more than that. And as you know, something that's stem out of that is a high childhood mortality rate here, which is also very high as the maternal mortality ratio. So we have lots of challenges also, because if a woman has up to 10 children, how do you expect, and she's uneducated, how do you expect the person, the woman, to be able to really care for so many children? So problem of malnutrition and all that is still prominent here. And also there's this belief that contraception is harmful. So when they come to clinic, that is one other thing that we try to do to counsel them, that there are various options of contraceptives, and we try to navigate which is really suitable to the woman when they come, so that, because they have this belief that once they take contraceptives, it can make them come down with some other sicknesses, and some make them grow fat and all other that. So those are things we try to educate them on, so that they can choose appropriate contraceptive method. The chronic illness pattern, this is my opinion from the cases I see daily. The most common here is the acid peptic disease, which I think might be related to their lifestyle, what they eat, and the type of diets here. Another thing, type 2 diabetes is equally common, and I can also explain that because of that, their diet. This is a population that likes very sweet, sugary food, and they consume lots and lots, of sugar, flour-based products in this place. So another thing is systemic hypertension. And the pattern we have been seeing here is that their hypertension comes much earlier. We see hypertension commonly in people who are 20-something, in their 20s, in their 30s. So, and at times we want to start maybe an elaborate evaluation, thinking is a secondary hypertension. At the end of the day, we discover that most of them still have essential hypertension. So that is something that I have observed here. And recently we did a research on that within the department, which has been published in one of our local journals here. So chronic lower back pain and depression are common with our women here. That was me yesterday during consultation with one of the women. So what are the pros of practicing in a rural environment? I would say, from my experience, the flexibility of work schedule is one advantage I have here, because I can take time to go and do some school runs, attend to my kids, and come back. And I can also reshuffle my schedule daily, depending on what is my priority for that day. If the priority is training of the resident doctor, I can let that be what I'll focus on that day and take fewer cases to see. So I have that flexibility of my work schedule here, and also equally the opportunity to have hands-on experience of clinical skills, because we have loads of patients here, and even the few specialists we have are overwhelmed already. So they are eager, they are really, really willing to allow us manage some of these cases, except when there are already complications that we really need the specialist to manage totally without our maybe minimal input from us. So we see varieties of cases, and especially infectious diseases. Most cases that I've read when I was in medical school that I thought I may never see, working here has provided me that opportunity of seeing them. Something like myiasis, something like cutaneous larval migrants, something like schistosomiasis. This I feel like, oh, this may not really be common again. When you work in a rural environment, we know that some of them are still a huge challenge. Also, there are lots of opportunities for research for people who are really willing, eager to do research. So because it's like a green area, a lot has not been done. There are still many things unknown. So that working here gives me that opportunity. And on a lighter mode, I would say you don't have to face traffic hold up that people in urban area experience daily when they are going to work. I drive just 3 minutes from my house to my workplace. So that is a lot of advantage. I can go to the market within 10, 30 minutes and be back home. So that's another advantage. And equally, you have access to fresh vegetable fruits in the rural area. You receive lots of gifts too from your patients who appreciate what you do for them. So that is what I enjoy as a rural woman doctor. So how do I navigate through my challenges here? Like I've said earlier, accessibility to the internet provides a great opportunity for me. And I utilize that also for my in training and assessing my resident doctors. So I recently moved most of their assessments online. There is a program that I've already uploaded all their questions, their multiple choice questions. They do it and have their feedback immediately. So I don't have to sit down with paper and mark, so I'll delay them in receiving feedback. So that has been quite helpful. And at times, because trainers are very few, I have to modify their OSCE and oral exams. Instead of examining them individually, I do like a group examination for them. And it's equally effective surprisingly, it's equally effective. Group feedback, examining them in groups. So for my children, so what I do to supplement what they lack in schools is to get extra coaching classes for them. I get teachers. We have some youths who come here to serve from the South, who we often utilize as teachers here. And also educational application has been quite helpful for my kids. And I must say this, I have good family support. It makes it a lot easy for me. So I'll conclude by saying multitasking is very important, is an important skill for a woman practicing in a rural environment. You must be able to do many things at the same time, to schedule your days properly, what's are the tasks before you for that day, and to really do 2 or 3 things simultaneously at times. So it is possible to achieve work-life balance, working in rural area. And so I don't think a woman should be too scared to come to the rural environment. Yes, there are challenges, but technology helps a lot to mitigate the cons of working in a rural area. So this few here are some of the resources I know we can equally assess that talked about women health in the rural environment. So thank you for listening.
Thank you very much, Dr. Betty. And
Great.
we have really been brought to book to where you work, and we can envisage and imagine the population that you serve. I would like to, maybe members would want some clarification on issues or comments on some of the issues. Feel free to do that. I know we are few, so the discussion may be a little more expounded.
Just wanted to touch on 2 things with you, Betty. I think the first is the issue of women always seem to end up with having to run the family and run the practice, and that can be a real challenge, trying to do your clinical work and balance up your family and all those sort of things. It sounds like you've got a very supportive husband, but it still is, you know, quite an issue. So it sounds like you balanced that up particularly well, but it is with more women coming into practice, do you think they'll be able to continue to do that? And the other thing, I suppose, is just the technology. I think technology is helping us now to be able to run our practices and do our teaching on site without having to send people back to the big universities. It sounds like that's what you're doing, is teaching doctors in context using technology. So just, I suppose, that work-life balance and the use of technology, if you could comment on that.
Thank you, Dr. Bruce. I will agree with you that it is not that easy for a woman to work in a rural environment, and without good family support, things may not really work out well. Especially also if the environment or the community where you practice is a little bit hostile, or maybe they have a culture that doesn't respect women. Such a woman may really not enjoy working in a rural environment. But I still will say that we can still encourage women, because when we get to this rural environment, you see women who really need a woman doctor or a nurse to attend to their health needs, which they may not really be too free if it were to be maybe male doctor attending to them. So maybe there could be like incentives that can be given to women who wants to practice in the rural environments, something that will make it easy for them and their children. maybe a special consideration for their children's schooling and all that could really help and encourage women to stay in the rural environment. And yes, technology can help maintain work-life balance. You know, we have a lot of applications to do video call and all that. So I can call my mom, who is like 24 hours journeying away from where I work. So I can chat with her, see her via a video call. Though I know that is not like physical touch, but it still goes a long way in bridging the gap. And that really helps not to be too far from family and friends. There are friends, families that I've not seen in 4 years. This is my 4th year in this place. So, but we communicate using, you know, technologies that are available. So that's has really helped me also to achieve work-life balance. I don't know if I satisfactorily answer your questions.
Lovely, thanks.
Professor Bruce, thank you.
Thank you.
Thank you. Any other comments?
Dr. Barish here. Dr. Barish, was a very nice presentation. Nice to know how you're balancing your family life with your profession. And my working condition here is not much very different from you. I am in India now, eastern part of India, a state called Bihar, which is relatively backward compared to other states. And the place I'm working now is also semi-rural, you can say. They're trying to urbanize this place, getting urbanized slowly. And I am practicing family medicine here. And my wife, like the thing happens to be practicing gynecology. She's an obstetrician. So therefore, we have to complement each other. And a lot of things are very common when you're speaking of things and people, the education level over here, the awareness of health, people, they really lack out here, you know. And I can relate to a lot of things you have just said. And women, yes, I can see my wife managing the family and profession, and that is very important when women doctors are concerned. I think we must appreciate all women doctors all around the world, because at the end of the day, women have to look after both, and that balancing act is amazing, which you all are doing. So really appreciate that, and very nice talk from you. Nice to hear from you. Thank you.
Thank you. Any other comments? I wanted to find out from Dr. Betty. You mentioned something to do with the patients, the women find it prestigious to deliver at home. Is there any efforts that the Ministry of Health is doing to try and work on this, or are there interventions that are trying to address this kind of belief?
Thank you, Dr. Jane, for that question. Yes, it's an issue that is being addressed as one of the priority health concerns in the state now. And I'm glad to say that the state recently has a Department of Public Health overseen by another colleague who works in my facility too. So they've been doing, there's a lot of community efforts going on to educate them, and also involving their religious leaders, because that is they are like key stakeholders when it comes to changing the belief of this population. So they tend to listen more to their religious leaders. So if their religious leaders tell them, keep telling them something is good, is right, so they want to obey that, believe that. So they are making efforts, working on that.
Okay, thank you very much. Any other comments or question for clarity?
Thing in India as well.
Thank you very much, Dr. Betty. I am Innocent Besige. I'm a family physician here in Uganda. Sorry, I came late. I was in another meeting. And thank you for the insightful presentation, which is
thank you.
Yeah, which is really a reflection of what happens elsewhere in most of the African countries. For me, I just have two questions or comments. One is about respect accorded to women doctors, particularly if they are working in the rural areas. Here in Uganda, when women doctors are always referred to as nurses. And sometimes people don't believe that they are being seen by the doctor. So how is the situation there? And what has been your experience with some of the male patients? Do they accept to be cared for, or they, as it is for the women, preferring the women? Probably the male doctors would also not want to be seen by a woman doctor if you are the one on duty. Then the second question is, it's funny that many curricula for many medical curricula in many medical schools do not actually have a rural component. They just, and we know that rural health care has its own unique issues and unique challenges. So, but when you look through the curriculum, there are really very few curricula which have some component on rural health care training. So do you feel that the training you received prepared you enough to face the challenges you are facing in the rural setting where you are practicing? And what would be your recommendation? Thank you.
Thank you, Dr. Innocent, for these very valid questions. And thank you for your kind comments. And I will start by saying that before we used to have that challenge of this community not being able to differentiate between a nurse and a doctor. Most of them assume that if you work in an hospital environment and you're a female, you're a nurse. And if you're a male, even if you're a ward orderly, you're a doctor. But gradually, they are getting enlightened, and they know that, in fact, now they know that there are cadres of doctors that they are what they call them big doctors. They refer to consultants as big doctors. So once they know that whether you're a female or a male, that is a Baban Likita. That's the word in their dialect. Baban Likita means the big doctor. So they they are happy to see you, not considering your gender. So they know that, no, this one is the big doctor, not a nurse. And but people in the community in the interior still grapple with that kind of understanding. Many people because of that, many people are able to deceive them. Some will go there, ward orderlies, they will parade themselves as doctors, and nurses will go to those rural places and parade themselves as doctors and do a lot of quackery. But eventually, some of them come to the right facility where they are appropriately attended to. Yeah, my training has some elements of rural components because it is mandatory in Nigeria when you're doing family medicine to do rural posting. And but I would say the period allocated for training for rural exposure is quite small, because we do spend a month in a rural environment. It is compulsory. In fact, before a training center is accredited by the college here, you must have a rural facility where your residents can go, and you know, they man the place. They are like the main doctors overseeing the nurses and other community health workers in that environment. I had that opportunity during my training, and that really helped a lot in working in this my present environment. Thank you. So I would, what I would suggest, I think it is really important for every family medicine curriculum in Africa to have a rural component. In fact, you cannot really function effectively as a family physician in Africa if you have not been exposed to the rural environment. Because majority of the population that we render primary care to, that needs our service, are in the rural environment. And if you don't know how to manage or attend to cases that are common in the rural environment, you cannot function effectively as a family physician, because there are conditions, especially infectious diseases, that are like high in the rural environment compared to the urban environment. So if the training lack this exposure, it will really show a lot of gap in that doctor's practice. Although, you know, we are lifelong learners. So if such a doctor comes across that challenge, like it happened to me when I first got here, it's an opportunity for you to retrain yourself to learn, even on the job learning helps a lot at times. By the time you see 1, 2, 3 cases, you will be forced to go back and read around those cases and learn more about it. So I think even if somebody's exposure is limited during training, when they work here, they gain a lot of on experience, which actually makes them better physicians.
Thank you very much, Dr. Betty. Any other comments? I think that was very insightful, and for us running programs, that's very, very important for us to note, because like you said, the variety of the pathology that is within that work environment is important for preparation for the future career. Any other comments or questions from members?
Maybe the other question I wanted to ask Betty is that in some countries or some settings, people who work in the rural areas, which sometimes we term as hard to reach areas, are given some incentives. For example, here in Uganda, people who work in remote places and the lower level facilities, they are given what you call a retention allowance, which is actually sometimes even more than their overall, the actual salary. Is there such a thing in Nigeria?
Well, for now, I am not aware of such in Nigeria. So whether you work in urban or rural, it's the same salary, it's the same allowance. There's no such thing as rural allowance for now in Nigeria. However, I would say cost of living in some rural environments is actually lower than what our colleagues in the urban areas are facing. So, so that means you are able to save more than average, more than your colleagues who works in an urban somewhere like Lagos. I don't know if you've been to Nigeria before and you've seen Lagos, how crowded. So at times some will spend half of their salaries on transportation alone. I don't have to do that. Like I said, my, you know, the distance between my work environment and my house is just about 3 minutes drive. So that means I burn less fuel, you know, things, you know, those I consider as advantages. And facility-wise, there are some opportunities I have here that my colleagues working in the urban area don't have opportunity to. So I can be sent for training. I can be, like my husband is away now to attend the college exam. There is membership exam in family medicine ongoing, where if it were to be an urban place, is not yet, it may not have that opportunity yet, but because of this environment, because we are few here and we must have a representative from here. So those are some of the benefits I would say comes with working in a rural environment.
Eddie, you said you had, I think, 10 interns. Do you have much trouble getting other doctors in? And obviously there's a lot of junior doctors and not quite as many senior doctors by the sound of things. Is that the case, or is there a number of other senior doctors with you?
Okay, Prof. Bruce, are you asking about other junior doctors working with me?
Yeah, are there other senior doctors working with you? And then obviously
Okay.
you have a number of junior doctors. Are they easy to attract and get to come and work with you?
Yes, thank you. We have a visiting senior consultant who comes from another state to join us in the department, especially regarding the training of the residents. So he comes monthly, spend like a week with us every month to oversee the training and give us his own insights. So, and for now, we have a senior resident doctor who also helps in training the junior residents. And my husband, like I call it, is also a family physician. So we share this role in between us. But in a year or two, things will change because we have 3 of them going for exams now. They're about to write their membership exams tomorrow. So hoping that they will all pass the exams. Once they pass the exams, we have like 4 senior registrars in the department. And that will really go a long way in making training other younger doctors easier for me.
You sound like you've attracted young doctors very well. What's the secret to that you've had? Is it, you've obviously got the enthusiasm and got the interest, but is there something you've done that's helped to get those doctors with you, or is that common in Nigeria?
Thank you. Family medicine is a beautiful specialty, and it's growing in Nigeria. And I'm one of the advocates for the specialty wherever I go. I make them see the beauty of family medicine, how wonderful the specialty is, what other specialties lack in terms of interacting with patients, the patient-centered care that we offer. So with that, because we have clinical meetings every day, they are like, oh, they really want to be in this specialty. They want to be that doctor that the patients will want to see every time. When you let them see you practice as a family physician, they know that there is something different. And one testimony that I've heard from people here is that they want to see me, not because I'm better than other doctors, because they said, we like the way you attend to us. We are happy the way you attend to us. And that is what I make my resident doctors see, that see, you can be like this and your patients will value what you do for them. So I think that is one of those things that is attracting them to the specialty. No.
You're a wonderful role model. Thanks, Betty.
Thank you.
Thank you very much, Betty. Any other comments that members would want to add? I wanted to find out about how is the system in your country, the private in relation to the government system, or in your state? I know you have different states.
Okay, the relationship between the private rural practitioners,
yes,
or the private facilities and the states. Yes, the governments try to regulate the establishment of private hospitals, but things are not where they should be yet, because people still do things the way they like at times. And what I would say is that in Zamfara State presently, when you go to the interior, you don't see private hospitals like that because of the insecurity challenges. No doctor wants to go and risk his life because of money. So in those areas, it's still government hospitals that are available, and most of them are not even functioning optimally. That is why we have loads of them coming from those interior places to the town to see, to the place where I practice. So the regulation is not where it should be. In urban areas, people establish private hospitals. You can see like 10, 20 private hospitals in a very small population, That happens a lot, and equally you see loads of numbers of government hospitals. But that's luxury we don't have in the rural environment. Most of them are running away. Even private facilities don't want to come to rural area. They will not make their money. There's insecurity challenges. The government facilities there even cannot function optimally because of the same reason. Thank you.
Okay, thank you very much. Any other comments before we wind up with our take-home messages? Okay, thank you, Dr. Betty. I think we've had, and I hope Dr. Bruce was able to get a live streaming so that members who have been unable to attend can be able to listen in and hear for themselves what we're able to importantly discuss. And of course, among our take-home messages is, as we prepare ourselves for work in those environments, rural exposure in our curricula is very important to prepare the graduate for that kind of experience. Continuing professional development, as the presenter has mentioned, to allow the family physician to have lifelong learning is very important to keep them interested in their work, but also to be able to continually mentor the persons they are working with, and also the young ones that may be interested in the discipline. Of course, technology, like Dr. Betty has mentioned, is very key to keep you glued to both the professional environment and your social environment is important. A work-life balance is necessary, and so that you can continually function, but also be able to give a service with much flexibility. And to crown it all, I think among the main take-home messages, family support is very key, so that the others can be able to work out for the practitioner. And of course, like she mentioned, the amount of work is a lot, and a lot of multitasking has to be embraced so that one is able to manage, but also get the patients interested in what you're doing. Thank you very much. Unless anyone has something else to say, we would like to thank Dr. Betty for your time.
Thank
for
you.
sharing with us that inspiring experience.
Thank you.
Yes.
Thanks, Jane. And I might just also thank Betty. It's been very inspiring to hear you, and there's not many doctors who can attract other doctors to their practice like you have. I think that's a real credit to you.
Thank you.
Particularly as you're a strong woman in your area to do that, and a great mother, obviously, as well, to those both your own children, but also those interns and the others who you look after. So thanks for that. I think this is as I said, in this month we've got the International Day of Rural Women, and I'll just share my screen just briefly, just to mention that there will be next week the WHO it brings together the rural equity area in WHO and the health workforce area with Theodora Swift-Kohler and Michelle McIsaac. So, and they'll be talking about the policies to attract and retain health workers in rural and remote areas, but very much also about promoting gender equality and making sure that that women are able to be equal parts of that. And that'll be happening next Friday. We've also got in there doctors from the Philippines. We've got community health workers. We've got Nagwa Hagazi, who's on our Wonca Council, and she's from Egypt. And also Issa Duambia, who's the Director of Human Resources in Mali. So I'd like to invite you to come and join us then. And also we've got a Afro PHC forum on rural primary healthcare and women in rural practice as part of the Afro PHC series. Innocent is the president of Afro PHC, and so there's a scheduled session on the week after to talk a bit more about rural primary healthcare and women in rural primary healthcare. So So thanks very much for joining us today, this evening, some of you this morning. It's been great, Betty, to hear from you, and thanks, Jane and Innocent, for bringing this together. It's a pretty hard gig in this COVID environment right at the moment to do all these things, and I do appreciate the effort that both of you have put together. So thank you very much, Innocent. Thanks, thanks, Jane, and thanks, Betty.
Thank you. And I think Betty has also run out of time. See you then.
Yes. Okay, and we'll talk soon. Bye-bye.
Yeah. Bye-bye.
Bye.